When we think about a failing heart, we usually picture a weakened muscle, a pump that has lost its power, struggling to push blood through the body, eventually leading to congestive heart failure. But arrhythmogenic right ventricular cardiomyopathy, or ARVC, presents a completely different problem. Patients with this structural defect don't typically show up with a weak pump. Instead, they experience sudden palpitations, fainting spells, or unexpected collapse. This diagram shows exactly why that happens. Look at the bottom left panel. The early risk in ARVC is driven entirely by an electrical failure, not a mechanical pump failure. The heart's rhythm is hijacked by electrical chaos, which presents a bizarre paradox. How does a physical, structural defect in the wall of the heart completely bypass the pumping mechanism and directly attack the electrical wiring? The progression of the disease follows a brutal, microscopic logic. The cellular glue fails, the muscle cells tear and die, fat replaces the empty gaps, the electrical circuits break, and the heart fibrillates. The true danger of ARVC lies in this exact deception. A microscopic flaw in the heart's physical architecture acts as an invisible trigger, setting off a lethal electrical chain reaction long before the muscle itself gives out. The sequence begins at the genetic level. Inherited mutations in specific genes, primarily ones known as PKP2 and DSP, disrupt the formation of vital cellular structures. This diagram shows specific proteins forming desmosomes, the microscopic glue anchoring heart muscle cells together, distributing the intense mechanical force of a heartbeat. Because of the mutation, these junctions weaken. Connections grow unstable, compromising their ability to transmit physical force. As a result, the simple mechanics of a normal heartbeat become actively destructive. With every single contraction, shear stress builds up along these weak points, eventually causing micro tears between the cells. The right ventricle is uniquely vulnerable to this damage because its walls are naturally thinner. When a patient exercises, the strain increases, and the higher levels of physical stretch end up violently pulling apart the compromised tissue. For someone with ARVC, the entirely natural act of their heart beating harder to support physical exertion actively destroys their genetically compromised muscle from the inside out. This chronic mechanical injury and structural failure eventually triggers apoptosis. Apoptosis is a biological process of programmed cell death, where heavily damaged cells initiate their own destruction. As widespread cell death occurs across the right ventricle, literal gaps and microscopic empty spaces are left behind within the heart's muscular wall, or myocardium. The human heart lacks the cellular machinery required to effectively regenerate new, highly specialized contractile muscle cells. To maintain structural integrity, the body is forced to patch these mounting gaps with whatever materials it can rapidly deploy. This diagram illustrates the patch job: dead muscle replaced by white fibrous scar tissue and yellow fat cells. This spackle is useless for signaling. The fat is non-excitable, while dense fibrosis acts as a rigid insulating barrier to electrical currents. The body's desperate attempt to physically heal the microscopic tearing permanently degrades the tissue's functional architecture. In trying to fix a mechanical leak, it unknowingly lays the physical foundation for an electrical disaster. In a healthy heart, electrical flow behaves like a single unified wave, sweeping smoothly and rapidly across the muscle to trigger a synchronized heartbeat. But the ARVC heart presents a severely compromised, hostile environment for that signal. As the heart's primary electrical impulse attempts to travel through the right ventricle, it repeatedly collides with the non-excitable fat and fibrous scar blockages. This forces the signal to slow down, detour, and shatter into multiple fragmented streams. Because these fragmented pathways are delayed, they often bend back on themselves, feeding the electrical current into tissue that has just recovered. This creates highly dangerous, continuously looping electrical traps, known as re-entry circuits. A re-entry circuit is an abnormal electrical loop that overrides the heart's natural pacemaker, causing rapid, uncontrolled contractions. These looping circuits are the direct mechanism behind the severe clinical symptoms we see in ARVC. They trigger ventricular tachycardia, an excessively fast heart rate, which quickly degrades into fatal ventricular fibrillation. Look at how this flowchart tracks the entire cascade. A single mutated desmosome creates weak adhesion, leading to mechanical tearing and cell death. The resulting fibrofatty scar tissue causes patchy conduction and reentry circuits, ultimately ending in dangerous arrhythmias and sudden cardiac death. ARVC demonstrates a brutal chain of biological cause and effect. A failure of the microscopic physical glue that holds our heart cells together is ultimately what shorts out the electrical grid of the human machine.